Hi, everybody. It's Thursday, not Tuesday. This is the MenoLounge, but this is our monthly edition where I get to share with you our in-house experts at MenoWell. We've got our favorite, Dr. LaReesa, hopping on today. But I just want to let you know ahead of time, hey there, love you guys hopping on here. I'm going to be on vacation next week because I got a big birthday. B-I-G. B-I-G. Jenny, you know what birthday I'm celebrating because I bet you got one too if you haven't had it because we're the same age. So it's a big deal. I'm taking a break. My family's taking me on a little trip. So you're going to have a whole week without me. Are you going to miss me? Yes, no. There's recordings. I'll be back. Let me bring up Dr. LaReesa. Just wanted to give you a heads up. Stay tuned for photos. Okay, Dr. LaReesa, where are you? I see you here. Jenny, I know, right? We're talking about post-menopause. Today is for our post-menopause girlies. Hey,
Mhm.
beautiful.
Hi.
How are you, Dr. LaReesa?
I'm great, but I feel a little underdressed
Why? You look gorgeous. What are you talking about?
because I had it all planned out. I was going to have a little birthday hat on for you. I was going to have like one of those little bazooka things or whatever.
Why don't you
I
go ahead?
don't-
Just make the noise. You know, you have kids.
Yay!
You're so
It's your
cute.
birthday. It's your birthday. It's your birthday.
I got
It's your birthday.
a week to
It's your
go,
birthday.
less in my 50s. I'm going to hang on to every minute.
Okay.
Although at the end, I'm going to be like, "Uh, see you later. Thank you, girl. I'm done.
Well, happy birthday. Because you're going
Thank
to be
you.
gone. You're going to like,
I'm out.
I'm out. I'm out. I'm out.
I'm going to an undisclosed location with my whole fam, my adult kiddos, parents, and like all the people. And so I'm really looking forward to that because, you know, that's actually what the best part about birthdays and aging is that, you know, to gather up all the people you still have. I'm so grateful. My parents are still healthy and can come along and, you know, like do the thing. And so that's actually way better than the birthday part. So I'm excited about
Absolutely.
that. And with your
Absolutely.
adult kids, oh, super fun. I told them,
Yes.
don't go crazy,
hmm
people. Don't go crazy. So,
And it's a culmination of so many things, right? Like 60 beautiful wisdom impact years, you
mm,
know? It's
mm,
just, and then for all the beautiful things that have been created, including memories and just relationships that have been developed and evolved. I mean, it's like what you say, the deliciousness of it,
the
right?
deliciousness of it. That is right. You know, I love that word. It is delicious. And look at Apple Pie said, no way, it's my birthday today.
Oh,
Woohoo! That song was for you
happy
then. All
birthday.
right. Does that mean what's today? The 20. So you're still in Aries, not quite into the Taurus land, right? Ooh.
Mhm.
All right, good stuff. Let's talk about postmenopause. Actually, let me turn on my focus here on my phone because I realize when we do these Thursday things, I don't have it
hmm
automatically set
Yeah, I was trying to adjust my light because it was kind of dark in here. I think one of my lights are going down, but
up here. Okay, I'm back. Are you back? Okay,
yeah.
okay, okay.
hmm
And okay, so I really wanted to talk today about being postmenopausal. I called it solutions, symptoms, and situations. Because my girlfriends are like, you know, everything now is for perimenopause, which is so funny because nobody even knew what
Really?
perimenopause was five
Mm.
minutes ago,
hmm
but the name, right?
hmm
And so let's just go into that because I'm not a doctor. I only play one on Instagram a couple times a week, but or when you're not available. Just kidding. But really, it's like everything is peri, and then really everything is post. Like boom, right? I mean, the minute you figure
hmm
out you don't have a period, you're post.
hmm
Is there even menopause, right? It's like we just go bip, bip. I don't know. What do you think about that?
I've honestly, I've gotten to the point of saying, "Are you menopausing? Are you menopausing?"
So ing, right? Okay. Are you menopausal? Are you I like that actually better.
Yes,
As
yeah.
the verb.
Honestly, because I love the advocacy. I love the awareness swing that we're having, riding the wave of all of that. At the same time, it's becoming such a buzz conversation that people are starting to get confused all at the same time. Like, well, I mean, even when I get patient call inquiries, I think I need hormone therapy. I think I'm perimenopause or something, in between or menopause or whatever. So even by the time I have the initial conversation, we're dialing in on, okay, let's focus on what you're experiencing, what's working, what's not working, and where we are now. Because right now you're menopausing,
You're
whether you're
menopausing.
on either side.
I love that. It's the new umbrella term, menopausing, because we're doing it for forever. I love what
Yeah.
Sharon Malone
Hmm.
says. You're postmenopausal for life. So it's not just like, oh, now
Yes.
I'm post and then I'm over.
Hmm.
It's over. I'm done.
Yeah. A
Sorry,
30-year life
sis.
is going to be part of all of that umbrella. So,
Yes. Yeah. Menopausing. That's what we're going to
yes.
say
Hmm.
in the MenoLounge land. Menopausing. Menopausing. That's
Just to
beautiful.
simplify today.
I
Yes,
love it.
absolutely.
Okay, so when we're
Hmm.
officially menopausing, although we should still say post for a
Post it.
second
Yeah.
because
Yeah. Yeah.
that was our
Absolutely.
promise for today. So
Absolutely.
because
Absolutely.
women who are, really more kind of far past post, like later in the 10-year window, which we need to talk about
Hmm.
that, are the ones feeling like, where am I in this conversation? So actually, before we talk about that, we should just
Hmm.
once again, what makes us postmenopausal? I'll let you define that one more time.
The at, I'm glad you mentioned, 'cause I was like, well, for definition's sake, let's review. Um, the moment that you are absent of a cycle for 12 months, and this is if a uterus is intact, then after that, you're pretty much postmenopausal.
Got it. But you
Okay.
also mentioned surgically, right? You can
Yes, so let's do surgically. So many times when the two questions that I always ask, because in layman's terms, it might be, oh, I had a total hysterectomy. Because what women remember is that how I felt after it. I'm
right.
good. I don't have any more cycles. But on the medical side of it, we usually are wondering, okay, if you had your uterus out, why? What happened? The approach, and did they keep your ovaries? Because it
Mhm.
has a different medical terminology. So if you had a hysterectomy, that means that your uterus was removed, but your ovaries may still be in place.
Mhm.
So if that's the case, depending on age and symptoms, you may not have any indication that you've had absence of a cycle because what the vehicle is gone.
Mhm.
So if you were menstruating prior to your hysterectomy, it does not mean that you went into menopause.
That's what somebody, I don't know, can't remember now who were talking about
Mm-hmm.
that. So if you still have ovaries after hysterectomy, which means you
Mm-hmm.
still have eggs, right?
Mm-hmm.
Then you may not be in menopause because
Absolutely.
still
Mm-hmm.
having eggs. Is
Mm-hmm.
that, and how do you get rid of
Yeah.
those things when you
Okay.
do they stay
I,
there forever?
yeah,
Is that
I'm
a
in
different
favor.
workshop? I don't know.
Well, let's simplify it.
Okay.
So, first of all, let's start with the equation. Hysterectomy does not equal menopause
Okay.
because menopause is truly dictated by the communication of your brain and your ovaries. So, when your ovaries start to decline and that feedback loop of your brain yelling at your ovaries to still do what you want it to do, and it's not because you have a significant decline of your estrogen, progesterone, and your testosterone. Will focus on those hormones today. And if that's the case, if your ovaries are still in place and you had a hysterectomy and you were still menstruating, meaning bleeding and having periods, that does not equate that you went through menopause. If at the time of your hysterectomy, removal of a uterus, that they removed one ovary, it does not mean that you are in menopause. The reason why I'm saying that, because a lot of ways that we did a hysterectomy at one point, we may have removed one, all right, and
Mm-hmm.
still kept the other. If you, at the time of a hysterectomy, had your ovaries removed, you did go through menopause, surgical menopause. So if both ovaries removed equals menopause, surgical menopause.
Interesting.
As you can see, I'm going through fourth grade math
No,
right
it's
now.
so good. I don't remember having this conversation with anybody, these distinctions around surgical menopause. Okay, so curious minds want to know what happens to those eggs if you have a hysterectomy, you have no uterus, but the eggs are still stuck in the ovaries. Now,
Okay.
what happens?
Well, so your body is just because it's surgically removed, your body is still in tune of, hey, I'm gonna give you a good example. The uterus is the brawn. It gets blamed for everything. And this is how I describe it to many patients and women. But the true, it's kind of like Pinky and the Brain type thing, right? And I hate to say it like that because the uterus carries babies and do all that.
Right.
But
Does all the heavy
honestly,
lifting, really?
yeah, but the true brains behind it is your brain and your ovaries, that connection. And then your uterus is responding to those hormonal imbalances from the environment or the peripheral areas of tissue and that particular communication as well. So if you're bleeding too much or bleeding too less, or you get fibroids, could be even more excess if you're more estrogen on board. A lot of those things are produced, of course, in the ovaries. So what happens to those eggs? They're just absorbed.
Oh, yeah.
Because so I like to think of it, remember when in our reproductive days, if you didn't get pregnant, right? And it would just, the body would say, hey, we're not pregnant, and then it will just slough out and then you remove it, right?
Right.
So just don't think it's like some little missing babies in your
Yeah,
system
I was
or
gonna
they're
say.
winning.
I don't want to.
They're really
I
a
don't want to know
collection.
that there's like 200 absorbed little embryos somewhere. That's not good.
No,
Okay.
no, no, because they're instantly die, once released. Once it does not have its place of where it needs to go,
Where it
it
adheres.
will go. Exactly. It will be reabsorbed in the body. So yeah, no issues there. So just to have a follow-up question. Oh, okay. Well, I have my ovaries. I had a hysterectomy. It doesn't necessarily mean that I had a surgical menopause if I was still menstruating prior to my hysterectomy. So a good indicator that you could be menopausing is symptoms, literally from, and then that's when you should go see your physician, because now we're matching age, right? Because a lot of times if you're in premature menopause, less than 40, or after 40, and then over 50 or average age of 51, any of those symptoms can come about. And if that's the case, then you can inquire and then we can follow up with testing. Oftentimes use a FSH or follicle stimulating hormone. And if it's elevated, usually that barometer is above 20, above 25, likely you are in menopause. But I will tell you this, I've had women well into like their early 50s have symptoms and still have a period, and that number could be really high. Like regular cycles. So the individualized segment, in which I love what my MenoWell, promotes, and especially with a lot of the people that you have as guests and experts. I love the fact of reiterating there's no one size fits all. You have to try to personalize your journey, educate and advocate for yourself just as much as anything else, and understand because of that, it may need to be cater to your particular experience and how we address your symptoms. So, so hopefully that was kind of ABC
No, it's
answer.
good. It's wonderful. We're so complex, but of course we are, right? Of course.
Well, I mean, men wouldn't function if we weren't
They can't
complex.
handle
They're
it.
too simple.
They're too
So,
basic. Okay. We'll bash men on a different one now. Love you, honey.
yeah.
Okay. All right. So you brought up the T word, which is a little controversial, testing.
Mm-hmm.
So some doctors are like, nope, you got the symptoms. Let's move forward.
Mm-hmm.
Trust yourself. Others are like, trust yourself and let's test so we have some kind of baseline. One, what's your opinion on that? And two, if you test, I still don't know, and I'll tell you, I was so post when I started. We'll get into that in a second, but what tests do you even ask for if your doctor's not a doctor that knows what to do? So one, what are your thoughts on testing? And two, if you test, what should you ask
Mm-hmm.
for?
My approach on testing is the latter. My approach on testing is, at the end of the day, I want a healthy woman. So if that is the case, her metabolic health is just as important of me addressing whether she needs to be on hormone replacement therapy or not. So my testing is more geared to, what are the things that we can be able to evaluate to understand your risk benefit profile, to see what else is underlying, because I do not want to promote any dogma of, okay, I just need to start HRT and we're going to be good, and we can just leave it out there. So I do tend to, and it's initially in my early parts of practice, I didn't. And sometimes I may decide not to, or like, okay, well, let's get you started now. I know exactly where you are. Or if I at least have some testing within 6 months to a year, then let's get started. And then we'll make sure to follow up on some other things. And so what kind of testing? Part B, I do get a baseline when it comes to your estradiol, your progesterone, your testosterone. Specifically, I like to do free testosterone, total testosterone, as well as something called your sex hormone binding globulin, which is SVHG. It's a short word to get an idea of what actually is being exposed in your blood that is the more functional or the bioavailable portion. So it helps me kind of calculate, okay, what is actually your tissue getting exposed to versus that, and a DHEAS, which is another. So I'm just going to batch and just put it out there. But other things I'm doing a complete blood panel. I'm evaluating your electrolytes. I love doing fasting insulins. I'm at least able to get where you are. If a woman is really struggling with resistance and, releasing weight and been on all the things, I might decide to definitely we do a leptin level. But those are some specifications. Now, specifically, because you had touched on this another time we had talked before, starting when you're more than 10 years out, I always do a lipid panel and make sure that we have an additional lipid panel. Because insulin sensitivity and insulin resistance, and then also on top of understanding cardiovascular events and as you age, and then that potential for chronic inflammation or inflammation at the level of your vessels, because estrogen used to be a part of keeping the elasticity or the integrity of those vessels. So if someone is beyond that 10-year mark that you noted, I am doing a more cardiovascular evaluation. Someone who's had an extremely abnormal lipid panel and they've been on statins for the last 10 years, I might go that extra mile as well, even if they're within 10 years, because you have to stratify the risk. Going back to that timetable, benefits, risk, you're always dealing with the system. All systems communicate with each other. And sometimes we have to think of it as the native biology and the natural biological process of a woman aging. And so when you're considering those things, then it doesn't hurt to me to evaluate and test. And if someone's open to doing more additional testing, I think we've talked about the Dutch test before, Julie,
Right.
And then there's more advanced technology testing, and it's available. That's the thing. It's available. And just because your insurance won't cover it doesn't mean additional testing is not out there, because once again, it further adds to the picture of evaluating your benefits risk ratio so you can have an informed conversation. And what's wrong with informed conversations?
More information, more empowerment. Yeah, I know it's interesting. When so because I went on hormone replacement postmenopausal at 59, I checked with a couple of different, online telemed that specialize in menopause. And then I went to my own Kaiser doctor. You and I talked, of course, but when I went to my regular doctor, she was like, well, okay, here you go, and here you go. Here's your estrogen patch, and here's your progesterone pill, and no testing whatsoever. And because I was 59, to me, postmenopausal, and I became postmenopausal at 51. So that's 8 years, a good 8 years. It seemed like I should have had maybe we should look at let's do some heart tests, So I had the calcium scan I always forget the CAC. What is that?
Uh-huh. Yeah, the calcium score
Score
test.
test.
So it's a CT, it's a CT scan that actually is going to evaluate the risk association with having underlying atherosclerotic disease. So basically plaques on a vessel level. And so once again, you're able to evaluate somebody's risk factors because what we do know, going back to that 10-year thing, is that the safety or the benefit profile of initiating hormone therapy within the first 10 years of menopause and or less than 60, the benefit ratio is much higher, according to all the other things pointing out to. Other than that, there's mixed opinion and mixed studies that we have to be able to, look at further. But even what was revealed in the WHI is that as women got older, you still had the issues of the aging process effects. So estrogen has not been on board for a minute.
Right. A
So
long
a
minute.
long time.
My
So
body was like,
therefore,
whoa, whoa, where have you been all these years?
so, but in the meantime, there could be plaque buildup. There can be inflammation of the vessels, more stiffening because of the lack of estrogen not being there.
Right.
So therefore, you're stratifying or changing that seesaw of that benefit risk ratio profile.
Right.
And so it may not be a clear benefit if we're talking about the risk of potential cardiovascular events, because though that is definitely increasing potentially as a woman ages.
Just
So
due to
that,
aging in general, and then any
yes,
other genetic or pre-existing conditions,
hmm
right? So we
like
have to
high
make
blood
sure.
pressure,
High blood pressure, right. Everyone in my
diabetes.
family is hypertensive. And so just to make sure, I am pre-hypertensive, just to make sure, because when you don't have estrogen in your body so long, then your arteries can, or plaque can get hard. And then you add estrogen, then the plaque can get soft again and break off. Is that the simple version of what?
I think that's a good version that people can pick
Okay.
up. Absolutely. Absolutely. Because everything is going back to inflammation. And it's interesting because I'm in different conversations of like this either minimum or just slow amounts of chronic inflammation on a daily basis. And that ends up being a cumulative effect. I even saw like literally my husband, I can't believe it, picked up National Geographic and I had a whole thing on inflammation. I'm just like, oh my God, they're doing this. But it's so important because what we're finding out, it really is adding to that chronic disease quotient. And then therefore it needs to be added in that postmenopausal conversation, because once again, we're going back to how can we do this where it is the most safest for you, where you can still end up with the benefits of brain health, bone health, potential cardiovascular health. You just want to have more information. And so, I mean, I have to give shouts out to a patient of recent. She did all her research. She came in and, she knew exactly what I was going to ask her because, she was over 60 and she was like, yeah, my doctor said my calcium score is 0. And I was like, okay.
Oh, I have to tell you about that. So I'm having my test in 2 weeks, I guess. But my doctor said, yes, I'll give you the test. But if it's anything other than 0, and that's the number we want, right? Will you take statins? What do you think of that? That was her. She
That's
said,
a
if you won't
good
take statins, I don't know that you should have the test, because that's the whole point of the test, and statins will help. Ah!
And we can have a sidebar conversation,
Okay.
but I guess my follow-up questions would be, yes, judging from familial history, following, how control your high blood pressure. Are you someone on 1, 2, 3 agents at this point and may have some early signs of either renal issues, which that's a sign of vascular integrity, might be a decline as well. And then also, have you had extended lipid panel testing where it's really looking at specific particles that may also add to that risk benefit ratio profile overall, in order to make a more conscientious decision of, hey, well, all these things add up, but okay, this doesn't really add up too well. So,
So I don't, yeah. I didn't want you to have to give me exact, like
No, okay,
personal.
sorry.
Like, you didn't have
Sorry.
to.
But I'm saying
I will be
considerations,
slacking you about that
considerations,
later. But in this moment, it was more that,
considerations. Hmm.
sharing with those who are listening, like these are the
Hmm.
conversations around when we have these tests and they do
Hmm.
give us more information, we're more informed, and be prepared because most doctors want you to take some action. It's up to
Hmm.
us, but still understanding. I wasn't really prepared for that response from
Hmm.
her. So
Okay.
I'm like,
Well,
oh, okay. I just said yes. I'll decide later after I talk to
yeah.
Dr. LaReesa, but right now I'm
Uh,
going to say yes.
okay. Okay.
Yeah.
Absolutely. Absolutely. I would, and you have to evaluate all options. And there's other things out there, things that, are being studied that can be used with statins or without statins to have equal or more benefit.
Mm.
And it's a deep consideration. And I'm just going to put it out there. As you know, recently my father passed away, but I remember reviewing his medication. So this is a practical tip. And we're talking about postmenopause, one of the biggest things are, the stress just on life and dealing, just being in the sandwich generation for our loved
Right.
ones. And I don't cancel or, regret any minute of it because I'm going to do it. And I just wanted always to be on the phone for during his doctor's visits if possible. But one of the things I used to do, I had a Google Doc like of all his medications. And I just used to pull it up on the phone and review because at some point, and this is not to, jab at anybody out there, it's, just because of how the system and, you're seeing so many patients. And so it's a possibility that certain reconciled medications to the pharmacy, they're still prescribing and the patient may not know you discontinued something. It's just simple things that can happen in that communication and dialogue. Get to the point, LaReesa. The thing is, he ended up on two statins, right?
Oh,
Two
wow.
statins,
Wow.
right? And then one was at a higher dose, one was at a lower dose, and he was someone that also was, complaining of muscle pain and we had muscle loss on top, so even catching those particular things and knowing that because of his cardiac history is something that he needed to be on. But, at that time he was aging.
Mm-hmm.
And I had advocated, well, I want him not only off the other one, but I think he needs to be at a reduced dose, because on top of that, I feel like it's decreasing, like plummeting more his testosterone level. Because FYI, cholesterol in your system is the mother of all hormones.
Ah.
So
Hmm.
so you have to have some cholesterol, something in your system, to produce a lot of the hormones that exist. So I just felt like with the whole picture of what was going on, that was making his muscle depletion even more,
Hmm.
on top of symptoms that he was having. So yeah, I get patients all the time scared of statins just as much as they're scared of hormone therapy. And I just lead with every action has a reaction. I just
Mm-hmm.
don't want you to be just put something on the wheel and then just let it ride. And the
Right.
same thing about postmenopause and hormone therapy. I think someone said it's just like when you're going on to ongoing traffic and you're getting on, onto the highway. What do? You look, you pause, you
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 ease
you
in
just go in there with into
slowly.
it,
You don't
right?
just go.
Same thing. Same thing.
Same thing. That's so good. Okay, that makes me think about my next question
Mm-hmm.
was, and I'm just using myself as a point of reference. So when I started HRT at 59, at the lowest level,
Mm-hmm.
0.32, I do a patch once a week, not twice a week, so once a week,
Mm-hmm.
0.325
Mm-hmm.
estrogen and 100 grams of progesterone.
Mm-hmm.
And I noticed that I don't actually feel the same goodness that I felt. That's the best word I can, deliciousness I felt when I first started. And I just wonder, since I started at the lowest level,
Mm-hmm.
is that an indicator that maybe I should go up one step?
Mm-hmm.
Um, Without giving advice, I'm
Mm-hmm.
just
Yeah.
saying, is that an indicator when you don't
Mm-hmm.
feel the same benefit,
Mm-hmm.
let's just say, that maybe you should go up? I've had other women tell them, hey, Trey, that their doctors just are constantly like raising the bar,
Mm-hmm.
like go up, go up.
Mm-hmm.
And they're like,
Mm-hmm.
what do I need to go up for? I'm good, you know?
Yeah.
So
Yeah.
that's another point of confusion for postmenopausal women
Mm-hmm.
when we start in the beginning, or some are start way up here and they haven't been on estrogen at all. It's just kind of,
Mm-hmm.
ooh. So give us some little
Mm-hmm.
insights on that.
I would say let's do it as just general tips.
Okay.
If for any medication, there may be various dosages, right? And the same thing for hormone therapy. And specifically, let's stay on the lane of a patch. So the lowest dose is a 0.025, which you can do weekly or twice a week. And the same thing for all the other laddered doses as you go up. And so it sounds like you're on the
What did I say? I said
375, 375. That's fine. That's fine.
I'm on
But
the
I guess
whatever
I
the
was
lowest one is. I can't remember, but I can't look back
it.
there.
Okay, no problem, no problem.
I put mine
But
back here, by the way, not in
I
front.
think
Okay.
I think a good measure for like anything, because I like to also remind people, same thing with thyroid, right? So any particular, it's still a hormone replacement, right? Diabetes, technically, you're on control, you're giving
Mhm.
insulin, right? So you may have to adjust doses based on therapy. And my general rule of thumb is start low, go slow, and then judging on symptomatic control, levers of whatever the goals were, because I try to identify what are our goals that we're going to hopefully quantify and qualify, and then based on that, I make adjustments maybe every 4 to 8 weeks if needed.
If needed.
And
Got
if
it.
needed, I don't do automatic. If someone's like, that's good, I'm good. Now, the only thing that I may consider sometimes, and these are practical things, these are like, because I've been doing this for a long time and trends and anecdotal, I'm not going to find this is clinical judgment and observation based on patients, friends, etc. So I tend to always do twice weekly patching.
Hmm.
One, over time, there's seems like always barely the patch holding on for the once a week one, or
Sometimes
finding
I'm
that
like on the last day, I'm like, hang in there, sister. She's starting to kind of peel up. I'm like, oh God, just stay. I need every little bit. Come on. Okay, good tip. All
yes,
right.
good too. So I usually will start twice weekly. I don't usually do once weekly hardly a lot anymore. And that's just based over time,
Yeah.
of doing that. Another thing is I noticed that people who are doing once weekly, they would notice that drop. And that's when I kind of have an idea of like how they metabolize certain medications or what may be interfering. So if I notice that, they tell me I notice a difference maybe a couple of days prior to me changing to my next
Yeah.
one. And I find that the twice a weekly, they may not notice that a lot. So that's why another reason why I might do
Tip of the
that.
day. If you're a once a weeker and it's not working as well, go
Mm-hmm.
to twice a week before you go up in a dose, right? Test
Mm-hmm.
that out. So smart.
Exactly. And then, if they have adhesive problems, I might have to switch to a brand versus a generic or vice versa. So I might not necessarily totally ditch a formulation. I might tweak
Mm.
something just based over time and seeing, just how people may respond. Because a lot of times it may be, okay, this is what your insurance approved and this is what you got, or this is what the pharmacy had on hand or what have you. But over time, definitely twice weekly, majority all the time I do if I'm doing the patch. And then if I notice that there's an adjustment, I may ask more specific questions and see if it makes a difference between brand or generic before I up the dose. And if somebody's like, I'm, still in zone like 10, we're definitely
Yeah.
going up.
Zone 10. Like, ah. It really helps my brain
Mm-hmm.
fog, which is that's what
Mm-hmm.
I wanted. I feel pretty good about the other stuff, pretty
Mm-hmm.
under control. And then I told you, although I was the part I said to you, why did you not tell me I'd be sleeping way better on progesterone? Oh
That's
my
some good
God.
stuff.
Although that I feel like I am not sleeping quite the same way. So
Mm-hmm.
does that tick up also? Or do you raise one, not the other, or do they both have to go up when one goes up? What do you do with that?
Um, can I inquire if you're on 100 or 200? Can I
Oh,
ask that?
100. Sorry,
Oh,
100.
okay. Okay. All
Yeah,
right.
I'm gonna
This is
Open book. There's
anecdotally.
no
Okay.
HIPAA happening here whatsoever.
This is
Right. Not
anecdotal. This
advice.
is not medical, whatever. Um, uh, if a woman is having sleep problems, 200 seems to always do better than 100 in
Okay.
general. Yeah,
Okay.
that's why the capsule tends to do better for sleep than creams or other formulations
Yeah.
of it. So how it's absorbed.
Okay.
But you may have to. And then another thing too, just in case, consideration, just making sure you're taking your magnesium at night and how much.
I don't take
Magnesium is,
magnesium.
oh, can you
Yeah.
please? Okay.
I
Okay.
feel like I'm in
Well,
trouble. I've been meaning to like I'm not taking any magnesium because there's
mm-hmm,
different kinds and then I couldn't remember which kind. I keep
mm-hmm.
forgetting to slack you to ask you.
Yes.
Okay,
Oh, that's
magnesium.
okay. That's okay. So in general, magnesium glycinate is a good one to
I
initiate.
should know that.
The way I inform patients is that there are just certain minerals and supplements and vitamins that are going to make your hormones better. But most importantly, remember, every action has a reaction. So you want to make sure your body is eliminating whatever the drug did, it did it, and then the byproduct is removed, or how your cell, like your cells are constantly metabolizing and doing their
Mhm.
biochemicals reactions throughout the day. So magnesium supports so many things when it comes to cellular health, your nervous system, and relaxing the nervous system at night. And so if it is, progesterone, of course, because you have a uterus. So let's say that if you have a uterus still there and you're postmenopausal, you definitely need to be on some form or progestogen. And she's talking about progesterone, which is micronized progesterone, which is commercially available, which is bioidentical. I'm just giving that little tidbit too.
Good, good.
All right. And so, but synergistically, I often find that using magnesium at bedtime with that may help as well, get that nervous system calmed down, but it also helps with a lot of the biochemical reactions that happen when taking hormones. So detox pathways, all of that, magnesium, complex B, vitamin D,
I take
omega
those.
3.
I
They're
take my
part,
D. I
yeah.
take my D omega threes. I'm just
Yeah.
drop off and K2, but
Hmm.
I drop off on
Hmm.
magnesium. Okay, do you
Yeah.
have a
Hmm.
range of milligrams that you're comfortable sharing?
Yes, no problem. So I mentioned magnesium glycinate. That's in general a good one to use all around. So anywhere grams. There is oils and sprays as well. I see Coach Angela
Coach
had mentioned
Angela.
that. So
Yeah.
yes, but I would recommend just making sure, because there are a lot of products out there, to just read how much is in there, because I've noticed they'll say blends of other stuff, so you never know how much of magnesium is actually in there. So that's the only like practical tip from stuff that I've followed.
Sorry, what did you
And then
say milligrams, LaReesa? Because
200 to
200
400
to
milligrams is
400.
usually.
Okay. Okay, thanks.
And then if you're tracking a magnesium, if you want to know your level, a good measure is called the RBC magnesium,
Mm,
not just the regular magnesium, but a RBC magnesium, if you wanted to add that to blood tests.
okay.
Um,
We're tracking.
and then magnesium threonate, that's one that I may recommend more for brain and cognitive support for women who are complaining or reporting more of like the brain fogginess, or just not as sharp, or, and it can still do very well as far as sleep. And magnesium has a lot of great properties as well. So just kind of
That's what
putting it
was
out
so
there.
confusing because
Mm-hmm.
of these different types. And so
Mm-hmm.
I'm always looking to optimize my sharpness.
Mm-hmm.
So maybe I need to try the theanate first,
Three and
magnesium
eight, yeah. Mm-hmm.
three and eight,
Mm-hmm.
like one, two,
Yeah.
three and eight.
Mm-hmm.
Still
Mm-hmm.
same 200 to 400.
Yes, but I will say most of the ones that I do have, or I may recommend, I have to look at the back of the bottle, because the magnesium glycinate or the other ones might have a more specificity of how much is in each one of those. But some of the brands I use may have a blend, and I know exactly where they're starting. So in general, 200 to maybe at the most 500 milligrams at night are good. But I'm just putting it out there when you read it or if you bring it to your physician, just based on how that ingredient breakdown could be. A lot of them may say 1 gram or whatever, but you have to look at, see exactly, how is it broken down so you don't feel like, oh my God, I'm overdosing or some on magnesium. So I'm
Right.
giving you general playbook, right? General playbook for a lot of stuff that you will find over the counter. So,
And just like food, read the labels, people. I mean, you need to know what you're eating, you need to know what supplements you're taking. And we have to, it seems so, I don't know, annoying is the only word I can think of. Like, oh, I got to read the label, but you want to know, and not just for macros, but yeah, we want to know how much protein, how much fat, how many carbs, how much fiber. But what else is in the thing that you're eating? We can use words like healthy and natural, ugh, but you got to read the label to know. And same thing on supplements. Look at the back, see what's in it. Is it a blend? What's in the blend? That's like a little tricky thing if it doesn't
yeah.
say what's in the blend. So let's educate
Yeah.
ourselves, and then we can be informed and ask good questions that way. So
Absolutely. I use the comparison kind of like jeans. We all know, I don't know about you, it's hard for me to buy jeans just offline. Like
jeans.
it has to be a pair of jeans. I have to know what that is. Why? Because most women probably do need to try on that pair of jeans to really see if it works. And then after time, you'll know, okay, does this have spandex? Does it not have spandex or whatever? But if you saw the Kardashians with some jeans on,
You're like, oh,
right?
those are cute.
It doesn't mean, yeah, it doesn't mean you're going to go after that gene necessarily, right? And so the reason why I'm saying that, that's the comparison of heart healthy, all the marketing things that are out there. And
Right.
that's why you have to read to see if it has spandex in it,
Right.
right?
Is there spandex? Because we need a little stretch. It just feels
We need
way
a little
better.
stretch. Yeah. It's great
Know what
that
you're
Kim
getting.
Kim got in it, but can I get in this?
That's right.
Okay. So I try to give people things that they can relate to,
Yeah.
because that becomes part of, there's a lot of stuff in the food industry that doesn't necessarily have to, be marketed the way it is, but it is, and it can be a false pretense of what you think you may be taking in, but it might not necessarily be what you need. And not saying
Right.
it's bad, but it's not maybe what you need, especially if you
Good
have
point.
certain goals in mind. Yeah.
That's right.
So,
Goals, and then is it what you need based on your
mm-hmm,
goals? Barb
mm-hmm,
and I talk about all the time about
mm-hmm,
intermittent fasting. Like
mm-hmm,
it's not terrible, but it's not good if it doesn't match goals that you have.
mm-hmm.
So, adjust your window based on your goals. Same thing with
Absolutely.
supplements,
Absolutely.
hormones.
Yeah.
What are your goals, and match to your goals with
Mm-hmm,
your expert advisor. So if somebody
mm-hmm,
wanted to reach out to expert advisor Dr. LaReesa, what's the best way they
mm-hmm.
can find you?
Yes, you can find me here on IG, Dr. LaReesa, LinkedIn on Dr. LaReesa Ferdinand. And if you're in the Florida area, I would love to see you as a patient. So you can go to
Okay.
thrivebeyondwellness.com. It is my own integrative medical wellness here in Orlando, Florida. Hopefully expanding in the next year now that I have some things with children all under wraps.
Yes. And congratulations to you on your two and a
Thank
half
you.
year journey to
Yes.
adopt your beautiful baby girl.
Yes. Yes. So yes. So that's another reason I was supposed to have a hat on today. So thank you, Julie. I receive it.
Yeah.
And definitely goes in line with this week is Black Maternal Health Week.
Mm,
So I feel like I have a different story to
mm,
share
mm.
over time. So it's a great thing.
Such a blessing, such a
Hmm.
blessing. Dr.
Thank you.
LeReesa, you are a blessing to
Oh, thank
me
you.
personally, MenoWell women out there. Thank you for all you do and how much you care. And you're not even menopausaling yet.
I am menopausing.
Oh,
I
menopause,
am.
not
I am
menopausaling.
menopause. Yeah,
I
I
threw in the
am
extra L
menopausing.
just for emphasis because I'm extra like that.
That's okay. I am menopausing, but just, for those out there, yeah, but I did have a hysterectomy and I still have my ovaries in place. So, I knew that there were certain factors that I could still be looking for, even though I know I wasn't at surgical menopause. So
Yes.
going back to what we had talked about at the top of it. So go back, replay. We broke that down. And happy birthday, Julie. The
Oh,
happiest of birthdays, and
thank you.
celebrate like a rock star you are, I tell
Yeah.
you.
It's going to be strange when I come back on the MenoLounge next time. I'm going to be 60. What the heck? I was
It's a
going to say a
number.
different word, but I'm just going to keep it nice.
It's a number.
It's a number. It's a real number,
A
LaReesa.
real it's a real number. But just think of all the things you've done over this time and those people that weren't able to see it.
Hmm.
That's a blessing
Well,
within itself.
thank you.
All
Thank you.
right.
Hopefully, I got
All right.
60
Thanks,
more to go.
everyone.
Just saying.
Absolutely.
Thank you.
All
Thank you,
right. Take
everybody, for
care,
being
everyone.
here. Go get them
Bye.
postmenopausing women. Okay.
All right.
Bye.
Bye.